And if we could invite our four remaining panellists before lunch to join us on stage, and we will have our final discussion before we break for lunch, just after 1 o'clock. And that discussion is about the immediate challenge, really, and we've touched on it throughout this morning's sessions, and it's one we've been discussing for many, many years. How do we recruit healthcare staff, from consultant through to nurses, everyone else besides? It doesn't stop just with recruitment, of course. How do we retain the staff here in this country as well to work in our health sector? We're joined on the stage by Leah O'Toole, who is Assistant National Director with National Doctors Training and Planning at the HSE, Dr. Rachel McNamara, a medical doctor and a National Fellow for Innovation and Change at the HSE. Dr. Chris Luke is a former A&E consultant at Cork University Hospital, and Dr. Tony Kerins is Principal Automation Advocate with OpenSky Data Systems. You're all very welcome. I have three. Have I got? Oh, I have four. I missed you there at the end. Tony, thank you very much indeed. So I think there's 900 consultant vacancies at the moment, and obviously more nurses needed as well. What is the biggest challenge, Leah, as you see it, in terms of recruiting staff, first of all?
Sure. I mean, if we're talking, I'm going to focus on the consultant vacancies first, because that would be my area. And well, when we say 900 consultant vacancies, really in terms of the actual vacancies where somebody's not sitting in post, there is approximately 500. The rest are locums and temporary staff. And we have to remember, many of those 500 are new posts that we've appointed or approved in the last year. So when we're talking about our challenge of recruiting for those, we really should be looking back 5-7 years ago. And really we should be talking about workforce planning and how can we approach how we workforce plan in a better way. So what we have seen over the last couple of years is a huge increase in the number of consultant posts approved. We've had over 800 approved, but we didn't increase the number of our trainees going through our training programs 5 to 7 years ago, and that's how long it takes to train. So we already know how many people are exiting from our program, and that's why we're facing such a challenge, because what we really needed to do was to train them and bring them into program that many years ago. So our biggest challenge really is trying to address the mismatch of the numbers of specialists coming out of our training programs and our number of vacancies. And what we have to do is start looking to see those specialists who've left Ireland, can we bring them back in? And we do need to look at our recruitment campaigns as well to start to fill those posts. Okay.
Rachel, what's your view on that question? What is the biggest stumbling block to filling those vacancies?
Yeah, so I suppose you could be talking all day about the myriad of factors as to why doctors and other healthcare workers stay or go into post. And you really have to start at the bottom and recognise that healthcare workers are human beings, and they have various needs as they progress through their lives, as they progress through their careers. And at the moment, the health service in many ways is not as, I suppose, flexible to those needs as it needs to be. In that, I suppose, for example, only or less than 1% of doctors at the moment work less than full-time in Ireland, and that compares to over 5% in the UK and to much greater percentages in other professions. And as part of my role and the capacity I'm in here today is around innovation, and we really have to look, I suppose, take a really user-centred approach to how we look at changing kind of features like that have just been long-standing in the system, that doctors, they work every hour under the sun, and that's the only way of doing it. There's so many factors that I suppose make it really difficult to bring those changes about within the culture that's there. But if we're really serious about retaining the workforce that we're training to a hugely high standard in Ireland, then we need to be looking at making those changes at the moment.
Chris, what's your view on this?
Well, I largely agree with what Rachel has said. I've been a consultant for 30 years until the end of last year in emergency medicine. And what people probably don't appreciate about working in an emergency department is that so much of our time is taken up trying to find, junior doctors to work the shifts. And that can mean every single day of a week that you're having to nip over to human resources. I was also director of postgraduate education in two of our biggest hospitals on either side of the Irish Sea, so I have a particular pastoral inclination. I personally, I can get very passionate about this. I have a daughter who works as a young doctor in Ireland at the moment, and I think that there's been a failure not only of manpower planning, as we've heard. That's been dismal on both sides of the Irish Sea. There's been a complete want of proper foresight and manpower planning. And having spent a few years with the HSE board until recently on their safety and quality committee, I have been encouraged on the one hand by the future of the health service, because I've come across some very bright people, but I have not been persuaded that those at the very top truly understand what those at the very bottom or those at the front line are going through. And just to echo what Rachel was saying, I am not convinced that those in charge of the healthcare system truly understand what caring means. I do not believe that the system cares for the carers. That sounds trite, it sounds cliched, but I'm telling you, I am absolutely passionate about this. I am by inclination a good Samaritan, but I have been broken by a system which does everything it can, it seems, deliberately to hinder and impede my efforts and those of my friends and comrades. So I think that we need to bring people up, nurture, cultivate and appoint people who truly understand what it is to care. And I'm afraid that typically means people who have been clinical or who have experience and pedigree in caring. I also think that we need to think a bit like big tech. Recently, as has Gillian Tett from the FT wrote in her book, Anthrovision, big tech, now the biggest of all the tech sectors, plus manufacturers and so on, have brought in anthropologists to study their market, the cultural values, the mores, the preferences of the people that they serve or are trying to sell to. And I am convinced, having spent 3 years, I've spent nearly 40 years with a worm's eye view in the emergency departments of these islands. And I've had the privilege of a 3 years bird's eye view. And I am convinced that what we need is an anthropological view to explain the way doctors have changed over the last 40 years. That's arguably the most important thing. For example, there's this endless talk about doctors need to travel abroad. No one has ever disputed that. But as a director of education and as consultants in giant emergency departments, typically with 30, 40, 50 doctors in training, I have always said that I would prefer our trainees went abroad in their third year. Because as I've heard when I visited Australia, that's when the receiving systems prefer to get our guys, because when our guys go at third and fourth year postgraduate, they are incredible. They have so much clinical experience, because that, of course, is the upside of the downside. The downside of our system is that it's overwhelmed and difficult, but the upside of that is that they're so tough and resilient and highly experienced by the time they travel, or the way they used to. But in any event, the bottom line is, I think that the politicians and the professionals in charge of the civil service and the HSE need to deploy anthropologists, because they are truly neutral listeners who can listen to nurses and doctors and all the healthcare professionals that we're actually talking about today really indirectly, and find out what it is that they treasure. Because, for example, we've known for 30 years that many of our undergraduates in medicine want to work part-time. But as far as I can see, there has been little or no planning. I mean, there's been no manpower planning really in gross terms, but there's been particularly little or no addressing of the part-time preference of so many of our doctors. For example, that's just one example. So that's basically, and I suppose my other big suggestion is we really need a czar, the way we had a cancer czar. Tom Keane famously transformed cancer services in this country. There was one person with huge experience leading. I think we need the same. One person leading, someone with huge experience of training and dealing and pastoral care of doctors in training. We need one healthcare professional care czar, someone who would sort out all the nonsense with pay and salaries and emergency tax and filthy res rooms and filthy staff rooms and so on and so on.
I think that's volunteering. Put your hands up.
You might say that, but I couldn't possibly comment.
Tony, what's your view on this?
For that job interview. You probably know I had some points that I wanted to bring up, and I'd just like to thank Chris for hitting just about every one of them, and I've more or less wiped them out here. But what I would say, first of all, from an automation advocate perspective, I would just like to get this very clear with everybody. You cannot manage what you have not measured. And one of the key issues here, and you mentioned that about predictive analysis, is there seems to be a dearth of measurement or understanding of the measurements. But I do want to default to probably my safe place, which is 30 years in human resource management. And one of the keys to that is, and I would like to make it my new mantra, and maybe make it your mantra to anybody who's involved in HR in the audience, is let's take it out of the area of human resource management. They're not resources, they're people. And let's free up the time of our very, very good human resource departments and our very, very good human resource professionals. And let's free up their time so they're in a better position to come into what I would call phase 2, which is the human relationship mentoring. And you mentioned earlier on caring. What do they need? What are the needs? What is it that drives people? Not processes and not departments. It's what drives people. And when I was thinking about that, I was thinking, while predictive analysis is the ultimate goal, what do our people need? Now, one of the things I looked at, and I looked at a report recently, and this is going to resonate with everybody in the audience, whether you are clinical or whether you're administrative or whatever your job is, staff need, and everybody puts down competitive compensation. By the way, in 2000, I did a survey trying to find out, was pay the number one issue across the public sector? And no matter how hard I looked at and reanalyzed it, I couldn't get it to be number one. It was 2, 3, and 4. So the next 3 are very, very important. Opportunities to deliver a service that makes an impact on patients is at the top of the list. Second, professional development and training opportunities. You've got to make sure that that is key and built in. I know that over the years, Leah and her crew are certainly on that with Dime Digital, the integrated management. But another one is the supportive working environment with rewards and recognition. Just ask yourself those questions. Are we doing that? Are we measuring that? Are we asking the key questions? That's very, very important. And clear communication and feedback from management. If we put that in place, we're in a better place to be able to say to people, come work for us or stay working for us. You know, it reminds me, and I can't remember the name of the ad many years ago, that said, come for the prices and stay for the value. Well, in the healthcare, really, what we're asking people to do is come for the opportunity to care for others, but stay for the comforts of being cared for by us. And I think that's what you were relating to earlier on. But again, there's that depth of lack of measurement of that amount. What's needed? Where is it needed? And in getting granular on that, not just at department level, right the way down to ward level. What's needed at this level? And I'm coming at that from double-headed. First of all, process automation. Of course, I'm going to go predictive analysis, data, put it all in the right place, and then be able to examine it. And yes, I will advocate that. But at the end of the day, we're talking about people, and feelings matter. Why do they come? Why do they stay? Do you know that? Chances are you don't. And that's what needs to be examined.
Leah, what do you think when you hear that? Is recognising consultants, nurses, all the medical care staff as people, valuing them as people and giving them the opportunities to flourish through training, education, opportunities?
I 100% agree, because I think when services are busy, as they are, you know, where we get so wrapped up in delivering the service and making sure, going back to this point, that the resources, do we have the resources to deliver? We're forgetting that we're talking about human beings who have career plans, they're ambitious, you know, their number one priority is always their patient. And they get lost along the way. And just going back to Chris's point around this idea of a czar who is specifically focused in on this area, you know, I think that's a great idea, but I'd go a bit further and say, and harking back to our earlier session, we can't have it at a national level. It will never work if at a national level, at an HSE level, someone in an office is the czar saying this is the way we now need to treat our people. It needs to permeate right down. It needs to go to local level, and those priorities and principles need to be part of our culture. So when we talk about things like, why don't we have more flexible working for our healthcare workers, doctors in particular, really, it's a cultural issue. We can put out circulars, we can have programs where we try to encourage junior doctors in training to take up part-time working, but we're not seeing our consultants take that. We don't have a culture of that. So I would argue that, we would, if we had that specific focus, it's about trying to change the culture.
Rachel, why do you stay?
Why do I stay? So it was never really part of my career plan to go. I'd be very family orientated. I would have, I suppose, my mom is on her own since my father passed away, and it would never be on my list to be, like, I'm not a big traveller. So I suppose those are the very personal reasons as to why.
Exactly, and I don't want to pry, but I'm wondering how you feel when you work in the system.
Correct. So one of my other roles, even though I'm not here in that capacity today, was as part of the recent industrial relations campaign for NCHDs with the Irish Medical Organisation. And I've heard stories of, just really challenging circumstances for doctors in training that are trying to marry caring commitments, particularly for women have still traditionally taken the burden of caring commitments, and 70% of our healthcare workers are women. And it's really challenging as to why, as to how they can get from one stage of their career to the next. The working hours, you have roles that involve starting at first thing in the morning, 7 a.m., 6 a.m. And what creche or what caring facility, what help in the home can be mobilised to help somebody when that's their circumstance. So in terms of, we need to make things easier. And a lot of what causes burnout, studies have shown in healthcare, is that a lot of the time that you're working in hospitals, you're not doing healthcare. You're tackling really poor IT infrastructure. You're firefighting. You're explaining to people why they can't have care, and that's a huge challenge. And that's what contributes to burnout, is that you're not doing the thing that you I suppose you signed up for. And in the NHS, I read a study recently that over 13.5 million doctor hours per year are spent just doing workarounds for poor IT infrastructure. And that's where, we've a stadium full of health technologies out there that are really slow to be adopted into practice in Irish hospitals and Irish communities. And I think that's a lot of work that needs to be done as well, that we need to be empowering our healthcare workers to be agile within their roles and use these technologies and be able to deliver efficient care that they're proud of, that they can stand over. And that's the challenge. But I suppose in the meantime, there'll be more attractive prospects elsewhere.
Chris, do you remember a time when it was anything other than what it is now?
Indeed, I do. I started in Wexford in 1982 with the sister Kelly, I think, on the surgical men's ward, who would open the window at 7 a.m. regardless of the weather outside. And she hadn't forgotten Nightingale's great lesson from the Crimea. And it certainly felt that the Crimea was relatively recent back then. But things were better in some respects. Things were less oppressive. there was a rhythm. There was a circadian rhythm in most hospitals. The emergency department was quiet during the day. You could teach, you could chat, you could have a coffee, you could bond with colleagues and prep the place, and then you could get the midday surge, which would culminate with after the pubs closed at about 11:30. Everybody's snoring by about 1 o'clock in the morning. Oh, sorry, sister. Thanks very much, sister. And then they'd still shuffle out over the wee hours, and then that would be the daily cycle. So that was a very real cycle that's now gone. The idea that there are winter pressures is offensive. It suggests that the politician hasn't been studying her brief. The idea that senior consultants or senior clinical decision makers are not there weekends or out of hours is offensive. I spent 30 years in and out, all hours of every day of the year for 30 years. And it's incredibly offensive even to have it suggested that, oh, if only these fat cat consultants got away from the golf course or the counting house, we might have a better service. And this, this childish political mantras, we need senior clinical decision makers. Yeah. I was a senior clinical decision maker, and just as Matthew Cook said earlier in the last presentation, I can ascertain what's going wrong with most people within 5 minutes as they walk but it's getting that then the solution delivered. And I heard a lovely quote, or a soldier commentating on the Ukrainian war, today, this morning on the radio, and she was saying, amateurs talk about tactics. Professionals talk about logistics, which comes to what Rachel was just saying. I mean, I spent so much of my time running around, trenches that were packed to the gunnels with people and their loved ones on trolleys and all that sort of stuff, looking for chairs, looking for a space, answering that phone. Will somebody answer that phone, please? Is there any looking for stock, looking for sandwiches for the elderly lady who's been there since yesterday morning, and on it goes. So logistics in our emergency departments is often a nightmare, in the same way as the shortage of beds, the shortage of doctors, the shortage of nurses is, So again, it all suggests that there's been a real failure of planning. Not that there's been no planning, but that there's a failure to comprehend what is actually needed. And again, there's this complete dissociation, detachment from the top, between the top and the bottom. And now, as I said, I've been close to the HSE apex for the last few years, and I'm really optimistic, but I'm not convinced that they really understand what care is or who carers are. Anyway.
Tony, we have a question in for you from our audience. Where or how do you see automation playing its part in the solution to supporting recruitment and retention?
If we look at digitalisation and digitalisation transformation strategies and automation, they're about processes, they're about examining your processes. But I think it really, the key to this is not necessarily just the implements that we use. It's about leadership driven, getting the leaders to accept that I need to free up, and I mentioned earlier on, my human resource managers to become human relationship mentors. I need to free up my clinical staff to become carers again. And, Rachel, you mentioned it there a second ago. You spend more of your time filling out forms than you do caring about people. If that's the situation, the people who are responsible for that situation need to look at that, need to automate what needs to be automated. Now, I'm not going to come in here on an automation platform, sit down and say, well, this is how you automate. That's what you need to do. What you need to do is take leadership and ownership of that. Even to drop back to what you mentioned earlier on, the SAR, they're going to need data-driven insights. It's not just good enough to be able to say, we have a problem. Where do you have the problem? How do you have the problem? Why do you have the problem? And who are you going to ask about solving it? I mean, improved employee engagement and satisfaction is about asking people like Rachel, how can you do your job better? How can we free you up to do that? What is it that you do? Show me. And then you realize that 10 of the actions, of the 12 actions that you take in your morning could be automated. Automate those, and that's where automation comes in. But it's led by the top down and the decision that in my fiefdom, in my area, I'm going to make every effort to free up people to do what it is they're qualified to do, their specialist area. And that's not administration, automated.
Leah, does it take too long to appoint consultants? Is that one of the problems involved here, the length of time it takes to complete the process?
Yeah, I don't think anyone in this room who's been involved in a consultant recruitment process could say that it's the most efficient, swift process. It does take too long, and we do need to work on that. And it is part of the issue, because when I'm quoting the number of consultant vacancies, and we're saying that we're recruiting for 500 consultants, and half of those have been approved in the last 12 months. What I'm trying to say there is there's no hope that that half could have been appointed within 12 months. It takes longer than that. It's a very, very long process. So it isn't nimble, and it does need to improve if we want to get people in post, because I don't think it's acceptable to say that it's okay that 250 of those vacancies, we shouldn't even expect that the recruitment process will be anywhere near completion. So it is a very involved process, and I think there is work going on within the HSE to look at streamlining, and I think there is a difference between HSE hospitals and voluntary hospitals, and it's going back to the data. So when are we analysing which hospitals is the process going quickly or faster, where it's slower, where are the blockers, and we should always be going back to the data to try to inform our policies. And another example, just talking about when Tony's talking about the importance of data, when we're talking about retention, we need to know who's staying, who's going. So it's not the same for every discipline, it's not the same for every specialty, and it's not the same for every geographic location in this country. There's patterns, and until we're identifying that, it's very difficult to come up with a national strategy. We need to have strategies that are pointed at those problem areas and looking at that in a concise way.
Lots of texts and messages coming in on Slido, agreeing with the points that you were making, Chris. HSE currently provides almost no funding or time to HSCPs to develop selves and or their service. Flexibility is actively discouraged, with limits put on staff that pushes them to leave. HR is a controlling rather than a supporting function. If we want healthcare to continue to be delivered by people who care, we need to care about those people. Otherwise, it will just be a job, and that will never be enough. And a final one for now, recruitment. There is a deficiency of healthcare staff required in all disciplines compared to those being trained. Going forward, what is the best way to identify this need in a timely way when relying on many different training organisations and the need for work placements? Where is the joined up strategy? Leah, would you maybe just take that one?
Sure. I think there is, it's going back to my very first point around workforce planning. So if we're looking at our training strategies, our training numbers, and what we need to the future, we need to be looking to see what is the right skill mix, what are the numbers that we need, and apologies, and are we training for the future service as well? So when we have that, then what we need to do is work back and work with our key partners in the training bodies within the HSE, local clinical sites, to make sure we have the places available. So I mean, I would advocate that from a doctor point of view, we need to increase the number of training places that we have, because we can see down the road, we have vacancies at the moment at consultant level, it will only get worse. And I think we just need to work in partnership to make sure that our systems are set up. And the other key point around this is, you can't just increase training and call everything a training place without actually investing in the programs. People need time to train. So if we, and we're going back to how people are treated and on site, people are pressurized. And if we now say, okay, well, we're going to increase all the training places, but we're not giving our consultant trainers any time to train, if we're not giving our NCHDs time to train, if we're not investing in training, in simulation, in good educational programs at site level, the quality is going to go down. So it's a race to the bottom if we don't start making those changes now.
Rachel, we heard earlier Professor Matthew Cook talking about clinicians who have left this country and maybe in Canada or whatever, that maybe they could do consultations via video. that kind of thing. And we saw an instance of that being referenced in the CAMS report recently, where a psychiatrist in the Middle East was carrying out consultations with teenagers by video. Is that something that could be considered? Is that an option? Would that be feasible?
I think absolutely there's a role for virtual consultations, like overnight. As on account of COVID, we had to dramatically change how we delivered care. I think there are some instances where it would be absolutely inappropriate to carry out a consultation virtually. I suppose particular specialties have come to mind, like particular instances or cases in dermatology. There's a tactile element to a lot of diagnostics. But I think we need to be a lot more receptive to those sorts of new ways of working and building them in, building that capability and that capacity locally. And I suppose another piece to that is that, and I think, Tony, you mentioned it around what is really important to healthcare workers is that ability to impact on the service that they're working in. And that ownership piece, and if you have an idea or if you see a technology you want to bring in from abroad and you see that happening and you see that working and making a difference, that fulfillment and that satisfaction is what will drive that retention piece. And like an example from the program that I work with, which is the Spark program, that an advanced nurse practitioner who saw how she could introduce the service to deliver hydration at home for children who were undergoing chemotherapy, which was something that was only ever offered in the NHS. We were able to help her bring it in over here. And she's so proud of that new service and the impact that she's able to have for these families who can now care for their child at home. And it's in that, there's so much power in that piece and in increasing your job satisfaction. And if you're fulfilled in your role, then you're not going to be looking elsewhere. And I think that there's a huge piece in allowing for that innovation and that scope for innovation within practice that's really important in keeping our healthcare workers fulfilled and ultimately delivering excellence in care for patients. Final word to you on this, Chris.
Where to start, but I mean, I think we've heard about many of the suggested issues that are going on. We can certainly tinker at the edges with telemedicine. We introduced tele-review for our patients in Cork 20 odd years ago, and it's something that telemedicine has huge potential. There's ophthalmology in telemedicine. There is orthopedic telemedicine going on in Cork and all around the country. But ultimately, the elderly people who are, of course, the fastest growing cohort for whom we are trying to care, like my elderly single working mother, and like Rachel, she's the reason why I came back, following a potentially very successful career overseas. She was blind at the very end. She needed the warmth of my hand. And she needed the warmth of carers' hands, people who spoke soothingly to her in a way that she could understand, who were sensitive to her values, sensitive to the local mores, and so on, which is the ultimate reason why we need to make sure that most of our staff are locally trained. We talk about air miles for food. I would suggest we talk about air miles for our graduates as well. But I'm eternally optimistic, and I think you have the brain power in this country and the people to effect the change if those at the very top would just listen to those who are trying and well able to care magnificently for our people.
Okay. Well, thank you all very much indeed, Tony, Chris, Leah and Rachel.